Good afternoon, dear colleagues. First of all, I would like to congratulate all of us on these great holidays, which the whole country, all our people have been celebrating recently, the New Year and Christmas holidays. And while we were coming up to the audience, we, together with colleagues, have just been discussing that this is the best event that we're here now, which can help switch to the working mode from the holiday mode. And this working mode will help us get to the working mode in 2016. It is great to understand that within the traditional Gaidar forum, currently we have a focus on our social industry, such as the healthcare industry. And healthcare industry is important for every single person, not only for people here in the audience and people from medical science, from some practitioners. It is important for experts, for high authority experts, for those who have been cooperating with us for a long time without being experts specifically in this industry. And they help us hammer out different great solutions. I wanted to emphasize that today, the day today started with a panel discussion devoted to efficient budgeting in healthcare. And there was a speech by the Minister of Healthcare of Russian Federation, Veronika Skvartsova, and panel discussion was devoted to different aspects and different areas of budgeting in terms of its efficiency, in terms of sufficiency and prioritization of budgeting, prioritization for most important areas which will ensure healthiness and the reduction of mortality. And we have discussed budgeting on different levels, on federal level and on regional level. And it is important here to have this expert discussion, a more narrow discussion, which will be devoted to key performance indicators for healthcare institutions. And we will be talking about how to set this KPIs, how to set these key performance indicators. Key performance indicators have become an integral part of the daily work of managers in healthcare. But we will talk about how to interlink the indicators on federal level within the industry as a whole, how to link these general indicators, overall indicators, to indicators on a regional level, and how to motivate doctors, every single doctor, how to motivate every single expert in healthcare institution for them to increase the contribution and performance. And the objective here is to improve health, of course. Naturally, we should ensure efficient functioning of medical organizations. Starting from the middle of 1990s, this subject has been very important. It has been discussed in all annual conferences devoted to healthcare. It was particularly loud summer last year when the majority of my colleagues who were taking part in this conference, there we were discussing efficient functioning of medical organization. And today we will have a chance to listen to respective speeches. We'll listen to success stories in federal level institutions. I will introduce you to my colleagues when they will be speaking. Some success stories from regional level institutions, such as institutions from Moscow region, from the capital of our country. Here we have a particular responsibility for what we do, and great level of quality must be maintained, and the level of is set quite high. Colleagues, I would urge you to have interactive discussion. I see many familiar faces in the audience. Please speak, please ask questions, so that we not just exchange opinions and best practices, but so that we can hammer out different practices and approaches which will help us in the future. And the first speaker is Valery Pavlov First, Deputy Manager of Healthcare of Moscow.
Thank you, Igor Nikolaevich. In my part of the presentation, dear colleagues, I would like to touch upon what Moscow, by now, by 2016, has come to in its definition of the efficiency of the operation of the healthcare institutions, such as the inpatient and outpatient institutions, and I will tell you the way we have linked these indicators to the bonuses that were paid to the senior surgeons and to the form of payment that is being received by healthcare practitioners. Let me switch this one over. All right. Before July 2015, we had a complicated system of paying bonuses to the senior physicians. We had many indicators, about 20, and more than 50% of what they paid depended upon these indicators being achieved. But most importantly was that these indicators were subjective. And we were gathering them on paperback from the healthcare institutions themselves, and they were fulfilling them themselves and signing off on them. And on the basis of that, we were trying to develop certain coefficients, and so the bonus commissions would be paying a bonus to a physician on the basis of that. In 2015, we made a decision to redo the system and define the kind of performance indicators which are necessary in order for a healthcare institution to be able to operate effectively, and most importantly, and I'm telling you about the clinics, outpatient clinics, to make the system affordable, presentable, and transparent in terms of the indication of the effectiveness. And the most important work was to define the kind of indicators which would be independent, unbiased, transparent, and we would be getting them not from the senior physician, but from the information system in place. And I will deviate from the topic of my presentation and would say that as of 2011, we started functioning the system of the single healthcare information system, which enables one to define in the outpatient clinics, I'm currently talking about them in the first place, the accessibility and affordability of the healthcare assistance. So both in terms of the GPs and pediatricians, as well as the specialists of the first and the second level. And in a daily way, the city authorities, including the mayor of the city of Moscow, can see what, during the past 24 days, the healthcare assistance affordability was in every institution. And so developing such an information system, which was created as a result of the funds which were allocated for upgrading and modernization, if you may recall, during those years, a lot of money has been spent on modernization of the healthcare system. So with the help of this money, it was set up, and its creation enabled us, and the subsequent modernization of it, and fine-tuning in the first place, enabled us to independently receive the assessment in terms of the affordability of the healthcare institution. I mean, the results of 2011 gave us the following results: that compared to 2011, the accessibility and affordability in the outpatient clinic on average, which is measured by the possibility to sign up for the GP, call within 3 days. So you come, you attach your medical policy to the scanning device, and you get within 3 days, then it's good. If it's not, then it's a poor indicator. 30% of people were not able to sign up until 2012 within 3 days. Today, it's just 3%. We were able to reach such indicator that only 3% of those who apply are not able to get a meeting with their GP within the 3-year period. And so, respectively, this enabled us to assess every outpatient institution on this indicator and include it into the performance efficiency indication. So there was a bit of a deviation. So let me continue. So this information technology system, something that was switched over to last year completely, in terms of the accounting, HR, personnel roster, also were immersed into this system, which enabled us to create an economic passport of an institution, which uploads on a monthly basis the performance indicators of every institution, including economics and their finance. Roughly speaking, we are able of looking into any list of indicators in terms of without individual names, and see what kind of wages were accrued to every individual without seeing their names, but also estimate on that basis the efficiency of the work done by every individual institution. Well, of course, the problem we started facing was how to assess the quality, and I will later elaborate on it. So that was the system that we have come to, being guided by the basic principle for these indicators to be objective, unbiased, and coming to us not from the senior physician, but being developed in an automatic mode within the MES, our IT system. And so our task was set for this year by the healthcare department for this system to demonstrate to us the achievements of every outpatient institution and the rating that they accrue based on the results of every month. On the basis of the indicators that we'll be able to see, a rating of every outpatient clinic will be developed, and the senior physician, having opened this system, because everyone has it, from the expert physicians, including the GPs, including the head of the healthcare department in the city of Moscow, as well as the Moscow authorities and the mayor of Moscow, have on a constant basis it uploaded on his computer screen in his office and on his desk. So you see these new elements of the outpatient clinic management, the per-specific indicators, the compensation based on the results. On a weekly basis, we have meetings with the outpatient clinic senior physicians discussing different instruments currently being applied. Well, let me take a look at a more interesting slide, which is the next one. It doesn't switch. Can you please switch it for me? Well, can we delay the questions for the later time, because we will have a Q&A session later on. Is frozen? Yes, the most interesting point. I wanted to go to the next slide, which are specific indicators which we're monitoring. These are 10 indicators in an outpatient institution, and let me list all of them. So 3 sets of indicators, as I mentioned, of an outpatient clinic efficiency, affordability, and quality. Every set within the indication system has a certain weight attributed to it, but altogether they constitute 1. So efficiency 35% within this unit of 1, affordability 30, and quality 35. So practically, equally divided. Now, what are the indicators which are applied to the efficiency? As said, well, first of all of us have switched over to the one-channel funding, and an important indicator, I believe, is production based on the medical insurance and per the core personnel. So we take the pool of best healthcare institutions, comparing them with the rest of them. I meaning to say which kind of an efficiency of operation done by the medical staff during the past period. No. Now, how much money a clinic received within a given month or within a given quarter, because the bonuses are paid on a quarterly basis to the senior physicians. So in this quarter, a clinic under the voluntary insurance, and how many physicians worked to achieve this amount? I mean, per 1 unit of a medical practitioner, which is an average one, how much efficiency was gained. Now, the second indicator, the share of non-medical spending, because we live in the kind of time that you have to count all of the spending down to 1 kopeck, and in the first place, the priority is to reduce non-medical spending, non-healthcare spending, I mean. Now, next one, please, if I may. Next, and the next again. Yeah, right, here it is. I'm talking about the second indicator, which is the share of non-healthcare spending. We're actively working on it. We have gathered the best practices from the clinics. For example, very simple things sometimes. Accountings, HR, legal support, because it's different in different places in terms of the quantities and the amount of money that they receive. So we've developed for the outpatient clinic a certain set of standards. How many accountants and lawyers and HR people and economists per a number of staff in terms of overall spending, and these guidelines were disseminated, and later on in terms of the quantities again. But in the first place, this is the wage fund, which is their priority because money is important. As a result of this work done, and together with the transportation costs, we analyzed the transportation as well. And I should say that on 2016, the post-specific task within this outpatient clinic, and as far as the spending is concerned that I've listed above, we are saving 1,200,000,000 rubles. So this is important set. And now the dynamics within which the average wage is changing. Of course, the presidential decree should be enacted, and so this is the indicator that we have included into it, and we are tracing the dynamics in terms of the wage increases. And I should say that the wage of the senior physicians, I hope that it's the case with everybody, directly depends upon the wages of the core personnel, because he's got a certain ratio, from the core personnel. So this individual should be directly interested in raising wages to the personnel, to the core people, to the core staff. Also, the wage spending, for the general administrative staff. So this 35% within the efficiency set are divided in between the weights in each indicator in terms of the output here. 13% and 35% within is 8 and 7. So these are the kind of economic indicators, rather, for efficiency, while the next set is affordability. Efficiency is, all of these indicators, apart from quality, just in the meantime I will speak separately about it, affordability and efficiency, are estimated and calculated automatically and uploaded for the Commission to make a decision, because the Commission goes into a session without any letters from senior physicians, without any papers, without them completely. Affordability of and if availability rather of GPs of the first and second level. It is also uploaded in the specific indicator 3% minimum one, which of the people who can sign up to have the checkups by these experts within 3 days period. Complaints and grievances. The number of calls for the first aid and the number of hospitalization. A very complicated process it is, because complaints should definitely be well-founded in order to deem them as justified. So far, we do everything manually. I mean, these indicators are being counted manually. So far, we're thinking about how to automate them. It's difficult to do so, but the calls for the ambulance, first aid, and hospitalization, they have to be analyzed, because these are not very simple indicators of the quality of work done. We're working on it, and our task for 2016, again, how to properly formulate and reflect the quality of healthcare services provided by outpatient clinics. This work was done during the third quarter, and the senior physicians already have received the first incentivization payments in Q4, covering Q3 results, and I'm going to show you the real live results. Well, it's not switching on again. Why? All right, so we will do it as before. We see that altogether we've got 33. Where are we? Out of 52 institutions, the indication of more than 0.85. I mean, one is 100% when the maximum bonus is paid. 7 institutions, the ratio in between 0.75 to 0.85, 17 institutions. Now, in between 0.75 and 76, 16, and less than that, 8. So that shows the correctness of indicators and makes it possible to make management decisions. I mean, 70% of outpatient clinics are in the middle of the aggregated rating, 15% below the average median level, and 15% show more than average. And here on this slide, you can see it, I mean, the real figures, and so it would be preferable to try, and certainly we've got a very good slide here again for the management decisions to be made. I can tell you later on, you can show the slide. No, this is right. So as a result, during various meetings with outpatient clinics with their senior physicians, we are showing the ratings of their operation based on the results within a certain period. And within each rating, these indicators are present, as well as a ratio that the outpatient clinic achieved in different colors. If it's red color, then you have to make certain decisions and think about how for this particular indicator to be improved and for the senior physician to work with it and improve it. If it's a blue one, then it's normal or green. Then you have to pay attention to others. And so these 10 indicators continuously going to be monitored. And the attention of the senior physician is being drawn to what they should focus their efforts upon and what is the indicator that they have to work in. I do agree that 10 indicators, they can be more than that. And they are quite different, all of them. But we even looked at some of the work done. And in some cases there were up to 100 indicators. Many of them were duplicating each other, so it doesn't make sense to have them. And it's very difficult to work with multiple indicators simultaneously, so we came to the conclusion that we would rather have less of them, but have them all easily understood by the people and the senior physician in terms of what they have to work with. And they will be assessed independently, loaded out of the system, out of the accounting systems, out of the availability systems, and will be automatically developed. The same apply. This enables us to achieve our strategic goals and inform the Department of Healthcare in Moscow, cascaded down to every staff member, and so the senior physician develops a system of bonus payments based on the indicators which we apply to the institution itself. These indicators were certainly discussed not only within the healthcare department at the city level, but also with the senior physicians, with the council of the senior physicians. We have a representative here who later on will be able to chip in. This is the first city clinic. And then we also discussed it with the trade union committee, and only after that reported to the government, to the mayor of Moscow, and respectively. Can you switch it on further, please? No, here it is. Right, here. Just leave it with that. So this is the kind of a matrix, so-called matrix, which shows the achievements of every outpatient clinic on the left, the top, the indicators, and the coefficients, which is being lighted in a certain color in order to pay attention to the indicators which are, not high enough compared to the rest of the clinics. And this makes it possible for our leaders and those who are in charge of the clinical work to hold the senior physicians accountable for non-achievement of these indicators, while those of them who are not achieving to understand how they should further organize their work. Similarly, I shall briefly now talk about the inpatient institutions so as not to waste your time. Could you switch it on further, please? Further? Yeah. This is the one. So these are the indicators available for the inpatient clinics have been developed specifically. The white ones, during the third quarter, we've been using the ones which are in rose color, because in the white ones, only as of January 2016, for example, the performance of the high-tech healthcare assistance plan, unfortunately we were too late in disseminating this plan, so we decided not to account for them in 2015, but in 2016 we'll do that definitely. So we've got two sets here, efficiency and quantity, for the inpatient institutions. The same kind of the efficiency, it has been augmented with an average length of stay of a patient and the average level of beds, and also in qualities the lethal outcomes and the repeat inpatient placement. Unfortunately, the inpatient clinics are only going to be submerged into the system that I described to you this year, like in the case of the outpatient clinic, and so we do everything manually so far for the inpatient institutions, but we're trying hard in order to automate the system as well, and by the end of 2016, the majority of indicators should be automated fully. Well, that I shall finish my story about what we did in healthcare area, and I would be ready to answer questions if there are any, and continue to discuss the overall topic. Thank you very much, Mr. Ivanovic. Yes, thank you very much, Valery Valentinovich. Dear colleagues, before we switch over to the questions, I believe it is worthwhile emphasizing that Valery Valentinovich presentations, he touched upon some very principally important and significant points for our subsequent debate. First, setting the key performance indicators throughout the scale of a region, starting from the work done by specific healthcare institutions through the example of an outpatient clinic, which is exactly the place that everyone encounters in his everyday life. I mean, including the Muscovites as well as the guests of the city, through the example of the GP practitioners, because I know that in Moscow this has been done in a very systemic way. And so it was very important to underscore the incentivization component, because the incentivization payments as part of an effective contract essentially directly are linked to the achievement of the key performance indicators. And the second important point that I would like also to draw attention to: utilization of contemporary software technology, which makes it possible to considerably achieve the efficiency in delivering the information about the key performance indicators achievements, as well as get rid of non-core excessive costs for the physicians themselves and for the managers within the healthcare systems. Well, please, questions, please introduce us. Well, I mean, we know you. Could you please say, because a lot of talk is going on about the standards, in between various, outpatient clinic work. Yes, this is one of the components, because these are the standards of the Moscow outpatient clinic, because, as you know, we had the crowdsourcing, process undertaken for the adult outpatient clinics. It has been completed by now, and so we are starting another project for the children's outpatient, and everyone can register and express his or her wishes in terms of what should be the conditions for the healthcare assistance provided in SCT outpatient children's clinics. Of course, one of the components here, I mean, the Moscow standard envisages an effective, affordable, available outpatient clinic which is capable of providing good quality services. And this is definitely one of the components of the Moscow standards. Apart from the rest, there are quite a few other things as well. Yes, go ahead. Thank you. Karpenko Ekaterina from the city of Bryansk. Do I understand correctly that your efficiency assessment doesn't have the monitoring of this infamous quality of provision of the healthcare services? I mean, there's no public opinion component in it. Yes, thank you. We are definitely going to take into account the opinion. We have got the text notification per every patient, and the feedback in terms of the quality, because 30% respond, 30% don't respond to the text message. Do you enjoy, did you like the service after the patient visits the clinic? And principally speaking, some very good results. And we're thinking about how to link this to the quality, part of it. But this is a relative indicator, because a patient cannot assess the quality of the healthcare services, largely speaking. But nevertheless, at least, what was the attitude he received and attention, because it's very important, in terms of the overall healthcare and how doctors treat you. So we're going to take this into account through other ways, not only through these ones, but through other ways also. Thank you. Elena Smirnova, Ernst & Young, but please tell you in what way you apply the quality indicators, why the ambulance call became one of the indicators. Well, the ambulance call, the GP is supposed to monitor the people that he's supposed to cover and monitor, to make sure that the service is timely, and put the patient into an inpatient institution also on a timely basis. If it turns out that an inpatient called an ambulance and visited an outpatient clinic before, and the physician that he met didn't direct him to go into an inpatient one, that was a mistake. That was a mistake in terms of not able to ascertain that the patient requires an inpatient treatment, and it all went down to an ambulance call. So we would say that this is the blame of an outpatient clinic physician. Well, I would like to support and underscore that this particular thing is one of the components of the technological monitoring, which, following the initiative of the Ministry of Healthcare of Russia, is being done in all of the Russian regions as part of a very specific work conducted to improve the healthcare of the population and reduce the mortality. And this is one of the reasons as to why the mortality is counted. And so the previous questions, I would say that you were talking rather about an independent assessment of the quality of services, and that is something that encompasses all of these social institutions, and serves as the basis of the subsequent development of the rating of such institutions, including the health institutions here. So, Valery Valentinovich gave us an exhaustive comment. Please. Institute Polyclinica from Krasnoyarsk. Could you please tell me, when assessing the availability, are you counting in the logistical availability of the diagnostic services? Are you assessing it in any way? And my second question, the state of preparedness of staff, of the personnel, what it should be before such reforms are to be launched. Well, starting from the second question, the readiness of the personnel. Certainly everybody has gone through the training and several times because physicians work in their particular places with the kind of a card. For example, they come to their workplace, they scan their card, and they start working on their laptop, on their desktop in this automated workplace, and fill out everything during the daytime. And press the button when every patient comes. We measure the length of time that the people are waiting outside of the office, the length of time of a patient visit, so it all is being monitored. If you would talk about the way the availability is being measured, I mean, when receiving diagnostic services, do you assess that? Oh, right, yes. Specialists. I mean, that applies to a non-GP kind of an assistance. So, yes, like the PET-CT and MRI, for example. Well, I mean, what's the question? Compatibility. I mean, in every outpatient clinic, we have done the reform in Moscow, and we went through reorganization. So every outpatient clinic has an MRI and PET-CT scan. We did reorganization in such a way so that the head institution, there is a place or premises for such a diagnostic equipment to be installed in order to have it everywhere, and all of the conditions are equal for these institutions. Outpatient clinic funding is done on a per capita basis as of 2014. As of July 2014, everything has been included into this per capita thing. And an outpatient clinic, whenever a patient comes in, if it doesn't have some kind of services which are sought after by a patient, it is supposed to write a directive and direct this patient to another healthcare institution. But as a rule, 90% of services is something that are available in every outpatient clinic. If not, then a directive is being issued and the service is being rendered in a different institution, for example, where you have a CT scan or something, for example, is not functioning. But that is being then counted off the per capita funding and being directed into the kind of institution where the service has actually been provided on the basis of cost. So there are, horizontal off-settlements. So an outpatient clinic is interested not to send people out to other institutions in order to in order to avoid having money written off its account. You mentioned the savings, but having heard the presentation, I can see that it has been a colossal work. Now, in terms of resources, how much money was required to develop the IT system, to train the staff? How much? Have you ever counted how much it costs? It's a commercial secret. I mean, no, I'm joking. I'm not in a position to tell you because we were assisted by the federal level, because the main amount for IT development was allocated as part of the modernization of healthcare system. And thanks to that, we've been able to develop this system because it has several sets, like equipment, and the third part of it, I think, was informatization. And as part of these allocations, Moscow didn't spend its own money. Primarily, it was done at the federal expense. We're just spending to support, and I'm not going to quote the amount of money that we're spending on this support. Please, the only thing that I would like to remind us all that we will have other experts speaking with their reports. So I guess that the first speaker, attracts the biggest number of questions. Yaroslav, the Agency of Medical Information. Well, clearly, the assessment of complaints is something that you have to take into account subjective impressions that people have, and you require serious analytics for it. But you also mentioned that similar kind of analytics is required by the ambulance calls, whether it comes or it doesn't. So what's the complexity of assessing this particular indicator and similar ones, please? Are you from the ambulance service? No, ambulance coming or not coming. So you mentioned, how you reflect that in your overall estimations? No, I mean not coming, but the call. I mean the complications is that maybe a patient never went to see a doctor, and that becomes the patient's blame. But on the other hand, working with a GP, we basically are we're basing us that the GP should know the patient that is covering territorially, and maybe he should have prevented. And for example, if it was a chronic patient or someone, if it's something of a sudden and a person never demonstrated any disease or illness, then we should analyze it, not just make a decision based on what we see. In Tulina, the first Sechenov's clinics in Moscow, my question is this: are you planning any public announcement of the key performance indicators of different healthcare institutions? For example, during the past few years in the UK, there has been a system whereby for different clinics there is a 30-day fatality indicating is being announced, and on that basis an independent rating is being construed whereby a patient can select for himself the safest clinic in order to go, as well as for the clinics themselves in order to assess themselves and improve the work they do. Yes, thank you very much for the question. A very good question it is, and a very important one at the same time. One should only think about what it would lead to if we try and do it now. But in any case, this is something that should be done. I do agree that this should be done by all means, and we're going to do that on the website of the department, but on the websites of individual institutions, so we will do that. Thank you very much. In some form or other. You mentioned that it's difficult to assess the quality of the services by the public. I'm not a healthcare professional. I'm just a receiver of the healthcare services of the patient, and so my question is, the last case, because the government officials are always saying, be very specific. A district clinic lost the results of the analysis pre-operation, pre-surgery, a standard set, which is quite a big, and you have to go through a lot of iteration to collect all of these analyses. And because of that, the surgical assistance was not done because the patient was sent on another round. Neither the district outpatient clinic hasn't been given any answers as to why this happened. And this is also a criteria of providing services, isn't it? And so if there were any public organizations, could you imagine such a situation that the public outcry would change? And about the IT system, what kind of a district clinic? Number 126 and 110. I mean the city clinic, the city outpatient clinic. Yeah. What I meant to say about the IT system when we were talking to the IT developers, because I, as a person who receives the treatment, was interested in various aspects of the IT support in terms of how it was done. So yes, indeed, very strong improvements, but no patient information, and the scope of work didn't have. At least these are the comments that I received from the developers. Well, in a very active way, we are introducing the electronic patient card. So far, it has been duplicated, and it is being done both on electronically and manually, but we'll switch over to the electronic form completely once we fine-tune certain legislative issues, and we will end up having the electronic form only. But I'm not ready to say when it will happen, because unfortunately I'm in charge of the economics in the healthcare department, not the medical services, and so it doesn't directly apply to me, but I know it, but I know that in the very near future this work is going to be completed, and that would definitely improve, and work would enable us not to lose anything, to issue the recipes that you won't be able to get basically in the paper form, but get it electronically. So it is already being done in the pilot form, and so as soon as it's going to be completed. Electronic recipes, yes. Prescription, sorry. But in as far as your particular case is concerned, we will sort it out. Yes. So, believe me, the healthcare department responds to all of the complaints and grievances. I would also like to comment and discharge, the tension. We have a person who is the head of the Federal Service of Oversight in Healthcare, Mikhail Murashko, and in every question we hear the word quality of healthcare assistance, and this is the service which reports to the Minister of Healthcare of the Russian Federation, which as one of their functionalities has this control over the quality of healthcare services provided during the past few years. The senior management of the service has undertook a lot of organizational efforts, and I believe that after these expert presentations we will ask Mikhail Albertovich to say a few words about it. Thank you. So if no objections, dear colleagues, I suggest that we should switch over to the next speaker, and to thank Valery Valentinovich, who in a very systemic way presented things which are being done at the level of the Department of Healthcare of the city of Moscow. And I would like to underscore particular significance of the kind of changes in improving the availability and the quality of the healthcare assistance and services which have been done during the recent years in the capital city of Russia, the city of Moscow. We also heard a question from our colleague from Krasnoyarsk, indeed, because Krasnoyarsk region runs from the north of Russia down to the south of it, and so it takes exactly the amount of time to fly, from the northern point to the southern point of it, as it takes from Moscow to Krasnoyarsk, right? Am I correct? And so I would like to underscore that despite the fact that Moscow is a more compact capital city as a subject of Russia, as a region of Russia, but in terms of the complexity of the organization of the processes, something that I preempted by the Andrei Valentinovich presentation, we have people coming to Moscow from all over the country with the most severe and complicated cases, and the federal institutions which work in Moscow, as well as the city institutions which are subordinate to the Department of Healthcare in Moscow, never reject anyone. And quite often we take the regional patients and receive them here, and in as far as this is concerned, the conditions for achieving satisfaction on the part of a patient about the availability and quality of the healthcare service is the most important bar, if you will, is the most important key performance indicator for the industry in general, in the eyes of the society, the government. And I believe this is a very tough thing to achieve. Again, I shall underscore because the bar is set very highly. So thank you very much, Andrei Valentinovich. I hope that you will participate in the subsequent discussion as well. Now I would like to pass the microphone to our next expert, who is an individual who has done a lot for this, and through the example of his own institution. This is Konstantin Lyadov, Doctor of Medical Sciences, professor who runs the Rehabilitation Center of the Ministry of Healthcare, and as well as the healthcare manager, done a lot to popularize best practices of an effective functioning of a healthcare institution, because essentially the conference that he organized and conducted in 2015, it really identify a lot of issues. What is an effectively functioning healthcare institution, both from the point of view of economics, from the point of view of clinical efficiency, from the point of view of public perception, in meeting the needs of the population and the government? What is an ideal healthcare institution? What are the components that are being built into it? Please.
Thank you very much. There were many questions to previous speaker, and these questions were clear, and I drafted a few additions to what needs to be said given these questions. Here, we need to assess not only the number of ambulance calls, but the number of people sent to hospitals with socially important diseases. We can assess mortality. We talk a lot about mortality. Who is to be blamed about mortality? The outpatient clinic, the hospital, or the patient who keeps on smoking despite his ischemic heart disease? So mortality can be also an indicator of efficiency of the clinic. And the incidence in oncology may be a negative factor for other institutions among the population that is attending these institutions particularly. So here we can add many criteria. Unfortunately, you see it all and we see it all, that right now is the time when the majority of criteria are economic. If we have a look at these ones, I took a picture of these ones from the presentation. Just have a look at these criteria: quality of work, quality of work in the clinic. The more the doctor works, sounds like it's good when the doctor works more, because the doctor needs to accept more and more patients, right? The more patients, the better. Maybe the quality will get lost, or it may not be lost. Like, we do not track whether the treatment was good, whether the diagnosis was right. It is difficult to assess it. We keep on thinking about it. The department keeps on thinking about it. But make it a criteria which would be assessed in a mass manner is a very difficult thing to do. Here we come to public organizations, to patients. By a patient, the work that we has done, does the patient think that it actually has some effect? because ultimately we have the following positions, so the following points of view. Point of view of a patient. A patient certainly thinks that the services needs to be high quality with no queue. It should be convenient if it's in inpatient, and doctors should be tactful and nice to you and close to home, close to home place. Uh, then the institution and the borrower, the lender wants to avoid complaints. Me, from the clinic, want to obtain as much money as possible. I want to provide the good quality, so I don't want to have too many patients to ensure quality, and I don't want complaints. Not that if we get all of this together, then just think what should be the criteria to assess it. Patient's point of view is not the only one. Colleague was talking about the UK social survey. A few years ago, two surveys were published. There was a question: are you satisfied by the healthcare services? And 80% of people said they are not satisfied. And then there was a survey whether you are satisfied by the treatment itself. And people were satisfied by the treatment. So people were not satisfied by the services, but they were satisfied by the treatment. And when the patient is coming out of the clinic, they were asked, are you satisfied with the clinic? Like, it takes long to get to the clinic. We are criticizing a lot healthcare reforms. I'm also criticizing healthcare reforms. I also think that it could have been done wiser, but I'm not the manager of it. But the reform is being efficient, and it is being proven it. Concentration of experts in different places and concentration of narrow experts. Maybe a patient will not be happy that he needs to go to another district of the hospital, to another part of Moscow, to get admission with another clinic. The quality will be high there, but the patient will not be happy because he needs to travel. A few years ago, we held a survey. And after this, we changed our manner of work with patients, and we realized that you need to actually work with patients. You need to explain everything to them. In 2011, everything was fine. We had these were great years. 2011, we had a good budget, and we were developing, and we bought MRI and PT scan. Number of patients growing, funding is growing. Everyone is praising us. Everyone is happy about it. I was speaking in conferences, and we held a survey. And all of a sudden, we found out, as a result of the survey, that 35.7%, I have a presentation, but unfortunately it's not working, 35.7 people who stayed in the hospital were not satisfied by nurses, and 22% were not satisfied by doctors. We had great indicators at the same time, and we were happy about ourselves. We had new technologies. We had high-level IT surgery. We had great rehabilitation. We were happy about it. But a fourth part of patients, were not satisfied by the way doctors work. 12%, they were saying that they did not understand what doctors were doing to them. They were not explained what was done to them. Having analyzed later, we realized that patients had to wait for a long time somewhere. And we took 5 social psychologists, and these psychologists were graduates, just graduates, and they did not work as doctors anywhere. And we let them come into this hospital. They had 3 tasks. There were 3 conditions. First condition, they had to spend more than 2 years with us, and then they would switch to some administrative work on something else, so that they don't have a chance to get friends in the clinic. And their task was just to question patients. What do you think about treatment? What are you happy about? What you are not happy about? So this was the first task. The second task, they were psychologists, social psychologists. Second task was to persuade patients, like, yes, maybe you had to wait for a long time. Yes, maybe a nurse was rude to that. We will work with that. Maybe doctor failed to visit you, but you was in the surgery theater. But I will put down your question and I will pass it to you. But what was the treatment? The treatment was fine. The treatment was okay. And when we made the same analysis in 2014, we found out that actually indicators became different, and there were no people who would fail to understand what what was done with them, and people were happy about nurses. Now, actually, we changed the way nurses work. Nurses work with patients. Nurses are responsible for talking to patients, for doing everything to patients, because surgeon do surgeries, right? And I'm responsible for the institution. I cannot keep a surgeon in the institution to answer the same questions over and over again. For the patient, for a patient, the surgeon is unique, but for the surgeon, this is one of many patients. So we introduced very simple solutions. And we realized that we just need to talk to patients as the equal part of the process. And we need to try and understand what is going on, and we need to explain what is going on to the patient. So we corrected the drawbacks. These drawbacks were very minor. Somewhere there were drawbacks in misunderstanding, in logistics. Like, yes, we had to say goodbye to a few doctors. Some doctors failed to understand that a patient is actually human and we need to work with them. Actually, there was only one doctor of this type. Ultimately, it led to the point that starting from 2014, we keep on working the same manner. We constantly change these psychologists once in 2 years, and ultimately patients trust us. The next thing we did, we're saying that we need to let patient go out of the inpatient clinic as fast as possible, because we cannot keep patients in the clinic for too long, and we have very good state-of-the-art technologies. He has nothing to do without clinic for long. However, patients usually would like to stay in inpatient clinic after surgery as long as possible. Uh, in some after some surgeries, some knee surgeries, patients are let out of the clinic like 3 days or 5 days after the surgery, and we used to do it 14 days after. We have a call center where patients call and find out when they can get to the clinic. Now this call center calls every person who have gone through the surgery in 1 week, in 2 weeks, in 3 weeks, in a month, in 3 months, and in 6 months. We do it all the time. We call all patients after surgeries. If these people want to come to visit the doctor again, yes, we admit them as fast as possible. If there are some complications, we help these people get back to the clinic. The patient with a complication after surgery must not go to outpatient clinic. He must not go through all of these difficulties to get back to us, because this is complication after our surgery, right? And as a result of this service, patients were fine about leaving the clinic like 5 or 4 days after the surgery, because they felt fine, they felt secure, because we would take care of them. And this is how we were tackling the satisfaction rate. There always will be some people who will be undersatisfied or not satisfied by something, but if we are not on different sides of the lines, if we try to contact patients, if we try to explain, then the result will be better. We should cooperate with patients. Surveys, is it good? Yes, it is good. It's very good for me. Is it good for chief experts, chief doctors? If a chief doctor fails to organize this work in the right manner, then we will have bad scores. Actually, when we were getting ready to the speech, we have a performance indicator. We've had it for a long time. Equipment utilization, and we annually fill out forms. Equipment utilization, they're called, and ultimately, so if the equipment for children, for babies that were born too early, if we underutilize this equipment, is it bad? No, it's not bad. So these criteria must be adjusted. They might be shifted a little bit. When the criteria is 100% right, this is something wrong about it. Colleagues who have been working with us for a long time, they've been unhappy for a long time about this indicator related to beds in hospitals, that you need to keep the patient for a long time after surgery. Now it's taken away. But we can we can keep patients longer if needed. I can let patient go the second day after surgery, right? If we follow the rules. We have a traumatologist, knee surgery. In the morning you do surgery. In the evening, you can let patient go. He said, "Yeah, sure. Why?" This doctor was saying that, like, you provide patient with the painkiller, and the same day after surgery, patient leaves the clinic, and he saves money because patient leaves the clinic, and this is something weird. If we keep on reducing the number of days in inpatient clinic for patients, and if we keep improving efficiency this way, there's going to be something wrong. It's going to be bad for health of patients. All these efficiency criteria that need to be adjusted, they need to be changed depending on technologies, depending on our cooperation with society, which is very good. But this is an eternal process. As my teacher would usually say, that I can keep on talking about the material for ages, about my subject for ages. Thank you very much. Commenting on your speech, I must say that on this great note, we can wrap, but we are not wrapping up. I wanted to comment a little bit on this as well. Naturally, you mentioned a very important point: satisfaction about the result of treatment, and satisfaction about the journey, about the process, about services within the clinic. These are different things and they have different criteria. And the second point lays within independent assessment of clinic's efficiency. We have certain ratings for this, and when it is ultimately assessed, the managers of institutions should be also assessed. Second point, which I wanted to mention, is that there's an ethical part of it. When we talk about efficiency, when we talk about wise approach in healthcare, it is not the same as saving money. It's a different thing. Here we talk about the quality of management, about efficient management, about the use of modern medical and organizational and different technologies. This is what we mean by saying efficiency. And you said the right thing about stage by stage provision of medical services, but patients should be aware of it. First surgery and then rehabilitation process. These are different stages. We should track them on the level of subjects of Russian Federation. This is important to track it. Do you have questions to Konstantin? Yes, please. Samsonova Alina Air Pharma. We are a Russian manufacturer of medicines. When developing KPIs, did you take into account such an indicator that was mentioned today by Veronika in her morning speech? That in order for the medicine to get onto essential drug list, now there should now depth of localization indicators taken into account. Depth of localization. Did you take into account these criteria somehow when you were developing your criteria? Because we know that the price of important products includes a huge share for marketing, for conferences, for medical representatives work. I guess it's a question to Igor Nikolaevich. Was it taken into account? If possible, could you please specify your question? We are talking about key performance indicators for medical institutions. And you were talking about essential drug lists now and about localization depth, and this is being developed by expert society. When you take into account when you take into account the treatment cost, do you take into account which product was used, locally produced product or foreign product? Um, Maybe my colleagues could comment on this. And Alexei, in his speech, will talk about it. When it's your time to speak, I will ask you to cover it a little bit. But you know that institutions, healthcare institutions, just like other social sphere institutions, they buy medicines just like other sources for medical assistance. They are being bought during tenders, in auctions. And we have a procedure where if there are three participants to the tender and one of them is a foreign one, then we exclude this participant. Given having a chance, let me introduce you to chairman of the commission from State Duma. I wanted to ask a question about beds, hospital beds. It happens so that I took part in the process and I experienced high technologies last year and the one before the last year. Last year I was let out of the clinic the second day. This year I was let out of the clinic 3 days after the surgery. The question is, like, I understand that when a joint is being changed, a surgery to change a joint, when a patient is not feeling fine, should we switch these people from inpatient hospital to from intensive care unit to rehabilitation bed in a hospital? Because a patient does want to stay in the hospital, but maybe we should switch this patient to another type of hospital bed. We're thinking about it now. We are thinking about second stage of rehabilitation, where it could be done and what should be the indications for the second type of rehabilitation. When the case is ready, if the second day you get out of the clinic, then you switch to rehabilitation. This is another stage of treatment. Of course, there are some people who do need further rehabilitation, and we have big rehabilitation centers such as Hospital number 10 in Moscow. Another point is that modern technologies, like you mentioned that you were let out of clinic 2 days after surgery. So how technologies helped you feel fine after surgery? So the majority of patients do have a chance to feel fine after surgery, like 2 or 3 days after the surgery. So we keep on developing. No, I mean, as to as to clinic number 10, we need to think about different types of beds in hospitals. Dear Konstantin, we have been in Bryansk for 10 years. We have been doing independent assessment of the quality of services. We are doing it on a voluntary basis, so we don't have social psychologists or something like that. But we would like Bryansk to have better conditions and better quality of treatment. The results of your studies could be useful to us. Maybe we can borrow something from your studies. Openness of the results of studies would be useful for scientific community. Moreover, we noticed that 75% of people are unhappy by doctors in the clinic as a whole, by the way they work, by their attitude to people in the clinic. So my question is, are you open in terms of sharing the results of your surveys with regions? Thank you very much. We never thought about it, but we will think about it. We have nothing to cover here. We are very open. We are very open. Thank you very much. And before I give the floor to the next expert with a very good speech, I would like to comment a little bit. Our colleagues agreed to place all speeches and presentations on the website of the Academy and of the Minister of Healthcare under the respective link. On central level and in regions, we are introducing a project Tactful Doctors and Nurses, and it's important to take into account the opinion of social organizations here. It's a good feedback, high-quality feedback. Now I wanted to give the floor to the next speaker, to the next expert. academician of the Russian Academy of Sciences, Evgeny Shlyukhto. He is. We have a great center, image of a great center here, and if you visit this center that you see on the image on the picture, you will be happy to see it. There are many organizational and technological and different novelties there. So Evgeny Shlyukhto is a manager of the Almazov Research Center, and if my task was to list the areas in which this center works and provides high-tech assistance to population of the whole of the country and other countries, also people from abroad, it would be much easier to mention those areas that are not a part of this institution. So based on this speech, I would like to now switch to the role of managers in healthcare. Managers in healthcare are very important. The role of managers is very important. Yuri, the floor is yours. Dear Igor Nikolaevich, dear colleagues, we're going through hard times. Everybody is saying there's not enough money, but hardly anyone says that we need to increase the quality of medical assistance, of healthcare. There are many challenges and many difficulties. I wanted to tell you that we have 4,000 surgeries now, 6,000 products that are registered. Just try to hammer out protocols and standards of treatment for every disease, given all of these proposals and options of clinical solutions, and progress in new technologies is very much in front compared to real assessment and real value, and it has been spoken about today. Also, I need to mention that we are saying there's not enough money, but we know many countries where GDP per capita and healthcare budgets are smaller than those of Russia, but they have better indicators, better performance. So improving quality in healthcare services is possible, and this is what healthcare department manager from Moscow was talking about when we this was mentioned when we were talking about expensive methods of treatment and expensive medicines, and we should compare prices and we can choose the cheaper options. Another point is that we are more focused by focusing on mortality and inpatient treatment, the duration of inpatient treatment. But right now, the paradigm of healthcare services is changing. We are focusing on patients' needs and satisfaction, and Konstantin was talking a lot about it. This is important. Another important point is that very often we prescribe too many medicines, thinking that it might protect us somehow. But we see efficiency metrics in the following way. We understand where we are now. We see that the majority of institutions in Russian Federation, and our center falls into this category, shows good results, but we understand that compared to these results, we have high costs for treatment. What should be used as the criteria of quality of treatment? And there are different indicators used. Opinion of our patients, of course, lethality indicator. Konstantin mentioned that institutions are interested in having more of severe patients. This way we will utilize equipment more, we will have more money. And the greater task of our discussion today is to think about key performance indicators that might be proposed on different levels for different institutions. Lethality, for instance. If we look at correlations between efficiency of institutions and lethality, the ratio between these two indicators. It's an important indicator, but if we look at lethality only, then institutions will reject patients with severe cases. They will switch to easier cases. And our experience already showed this. Next slide, please. Just as an example, pregnant ladies with lungs troubles. Nobody wants to accept these ladies. Ladies get pregnant. They hide it from medical institutions. They show up when the pregnancy is 22 weeks already. And this is a challenge. Every woman of this type is a challenge to us. What is the kind of lethality now? From 50 to 28% in best clinics starting from up to 2007. We have 15% of lethality, 2 deaths per 21 cases. In terms of quality, this is bad. Indicator has gone down. We had fewer lethalities. In perinatal center, we have 2 deaths already since the foundation. But this is actually a unique result when we are saving women who were deemed to die, to pass away as a result of their state. But this is a chance to deliver a baby and to survive. When we set key performance indicators for an institution, we need to understand and we need to take into account how it will influence performance in the institution, so that indicators that we set should stimulate development of the institution and provide patients with high risk to accept good medical assistance. Here is the dynamic of medical assistance quality. We have a special dedicated person who is doing this analytics. We have a special department that monitors quality. We monitor quality across the whole center. As to openness, on annual basis, we publish our report on our efficiency. This is public and available to everyone. You can read it. And you see that in 2015, key performance indicators that include clinical, economic, and diagnostics, and treatment, and lethality, and complications, they improve. The number of surgeries, we have 2,600 surgeries on open surgeries on the heart, and the level of lethality is much better than in Europe. It's 2 times better than in Europe. Heart transplantation. These surgeries are being done in Moscow, in our center, all of them. What is important? We improve results based on reducing costs for medications. 51 million in 2013, 44 million in 2015. The number of surgeries is the same, but costs reduced. We reduce lethality based on real improvement of efficiency. So when you improve efficiency, the most important thing about improving efficiency is using diagnostics and treatment technologies. There should be a good combination in terms of value and quality. Value for money. We should use economically feasible therapies and which will give good result. So we are very strict about it. Additional therapies, antibiotics, and medicines are prescribed only after visiting clinical pharmacologist. Which other sources can be used to increase efficiency? Register. One of the most efficient tools, register. We are registering coronary syndromes, oncology register, these lists. And our work, what we do shows that it is very important, and it helps us. Next slide. It helps us to register quality, to improve quality. We're talking about efficiency. Just have a look at this situation. We have everybody says that healthcare system is bad. Veronika was talking about it. Where is patient? Let's talk about the balance. On the one hand, healthcare system is responsible for the level of health, and healthcare system is so much being if there's a minor mistake, then this mistake is being multiplied, and everybody can see it, and we are viewed like under a microscope, a very precise microscope. Uh, and also a patient should also be responsible for his health. A patient goes through surgery, for instance. By 10%, we reduce statins intake, inhibitor APF, beta blockers, and in 1 year, patients stop taking these medicines. And in 1 year, this patient will come back, and all funds invested here will not be here. It will turn out that this money were in vain. Survival level. Survival level for people with heart disease. And it's an acute problem. Acute coronary syndrome, 10 to 12% of lethality. Other heart diseases, up to 1/3 of people with lethalities. If a patient stays sometime in inpatient clinic, then he leaves clinic, then in 3 to 6 months he will come back, or maybe he will come back earlier. There's a huge number of acute cases related to reimbursement to patients who compensated too fast, and then they were kicked out of hospitals. St. Petersburg, Samara, and Orenburg, survival 25-17-9. But this is not the most important point. Re-hospitalization level, 3%. In 2 times more in St. Petersburg, 7% in Samara, and Orenburg in 8.8. This is something to think about. This is room for improvement in terms of saving money. And here's the question: what should be the key performance indicator? Lethality only, and hospitalization as well. Next slide, please. That's why. Let me repeat. Minister of Healthcare made a revolutionary step. We are introducing a new approach to assessing efficiency of treatment. Right now, it is being introduced to inpatient clinic and outpatient clinics. This is the next step which will help us. So that there are many critics now. We need to assess based on the disease, depending on the disease, where treatment really brings good outcome. In some cases, myocardial infarction, the procedure must improve the quality of life. And patient does have a chance to assess the efficiency of assistance. In our center, we are trying to develop KPIs for this center. Performance, economic efficiency, HR work. So we are counting our money for every employee, per every employee. We have not launched it yet, but we will launch it per every employee and per every division. If we do not do it, if we do not improve efficiency in our institution, we are not going to be efficient. What we are going to do? Digital electronic documentation. We understand this is an important indicator. Telemedical technologies, monitoring of diseases. We're introducing it. We're offering our patients to try and use it, just as Konstantin was doing it. Rehabilitation. For about 10 years, for 10 or 8 years, we have been introducing the state-by-state system of medical assistance. There is no other way here. This system should be within the same ideology, within the same institution. Team approach. Team approach, not only in treatment, but also team approach in training, which is even more important. You should train a doctor, a nurse, and everyone who is all of these people together. And control over groundless prescriptions. There are services who are working with this. Results of telemedical monitoring of patients with hypertension. Resistant patients, improvement of state, 60%. This is a good indicator. Reduction of rehospitalization accounts to 26%. And reduction of bleedings based on anticoagulant therapy and strokes reduction. We have multi-profile. We have 24 profiles now, 24 areas, stage by stage, and standards and protocol in accordance with which we work. These are three main areas which help us improve efficiency in our institution. So what this two-stage system led to, we have a basic stage, then we switch patient to treatment and rehabilitation complex. Two-stage system increase the number of patients. Beds are expensive and they are used only when they really need it. But on the other side, we save costs by 15 to 20%, and indirect costs were reduced by 3 to 4 times, and hospitalization costs were reduced, and ambulance costs were reduced. So if a patient takes part in rehabilitation, then on 3 to 5 years, the money invested by the state are paying off. If the person does not take part in rehabilitation, then this money were spent in vain. They're wasted. Checklists and team approach example. We had a very complicated situation in a perinatal center. We 99% of women with complications in pregnancy, all acute cases come to our center. And our indicators were standing out, really. They were very high. We had to introduce a checklist, a team approach, training. As a result, by 12% we increased good birth, complications in birth rate was reduced by 0.9. We have 2,600 deliveries with the same number of beds. We introduced checklist and team approach, and indicators improved significantly. Reduction of costs in perinatal center by 20%. Next slide. And neonatal lethality there was an increase in 2014 to 11.3. So we had to respond to the situation somehow. Now we have 7.9, given the very complicated patients and general indicators of neonatal lethality are increasing, given that ladies are delivering with hypertension, actually. Ladies suffering from hypertension are having good deliveries. Qualification of people, key indicator of efficiency. It is very difficult to build a clinic, but to make a clinic efficient is even more difficult. It is very complicated. Team approach is important. Professional psychological training is important. Also, young doctors should take part in scientific and research work. This is very important. All clinical ordinators and young doctors protect theses, telemedical technologies, and electronic documentation. This is what people should do. And the final thing that I wanted to say is that everything is changing very dynamically now. Yesterday and today we're talking about proven medicine, like where we prove the effect. And tomorrow we're going to talk about medicine based on values, where not only the clinical effect will be important, but also assessment of patient will also be efficient. This value-based medicine is what starts tomorrow and what will be with us tomorrow. This is what Konstantin was talking about today. Medicine based on that we assess clinical consultations and we correlate them with other indicators such as social, economic indicators. And the most important thing is the benefit for patients. And patients should have a chance to choose. A patient should be an equal part of treatment process. A patient should understand advantages and disadvantages and risks of what we are doing to him. What is going to happen in the next few years? The situation is going to become more and more complicated. The value for treatment is going to be more expensive. New technologies will be introduced. Trainings, more complicated trainings. Unfortunately, our people, our staff are behind the state-of-the-art technologies available in treatment. These are technologies of tomorrow. Cell technology, gene technology, uh, new, completely new nano robots, and newer interfaces, and more and more new equipment and technologies. In this situation, we think that it's important to change the paradigm, to change development paradigm in healthcare. I think we need to develop individualized programs to develop institutions. Only this way the industry will be progressing. Individualization and flexibility. This is what Igor was talking about. It. Enterprises of different levels should have their own individualized KPIs, and our paradigm should shift from interests of institutions to interests of patients. Medicine should be focused on interests of patients. We should improve economic block, of course, and MOH is talking about it, and Veronica is talking about it. 3.5 thousand people were trained, people who are working. This should help us. We all should change, because not the strongest one and not the wisest one is surviving. The one who can change, who is able to change, is surviving. Thank you very much for your attention. Evgeny Vladimirovich, I think the applaud compensate for the lack of questions. If there are questions, I hope you will respond quite fast and quickly. I wanted to share my point of view about your speech and about your work in general. Dear colleagues, we had a chance to listen to a great, efficient practice of introduction of KPIs introduction. And these KPIs helped achieve great results of the largest interdisciplinary medical center and achieve greatest results of the global level, great results in treating, in provision of medical assistance and healthcare in some acute cases, acute medical cases. And people from all parts of our country and from different countries come to this center to seek to receive great treatment. The role of the team, the role of management is very important here. Evgeny mentioned these, and it has been illustrated in practical activity of an institution in the last 3 years. We should constantly be focused on innovations. Institutions should not be standing still. They should be introducing something new all the time. There should be constantly some innovative and new things. Yevgeny is not just, he has not just a medical center, it's a cluster, it's a scientific center. It is doing some trainings and research in different types of medicine. And he's training people and increasing qualification of doctors from different parts of our country. So they're focused on great result all the time, and they ensure it thanks to a good, balanced KPI system. We'll listen to Konstantin, we'll listen to Yevgeny, and people from European Medical Center will be talking about it. Andrei Yanovsky and Alexei Svyat. He's managing one of the most complicated hospital in Moscow, the Pirogov Hospital #1 in Moscow. They started working with the centers for a long time ago, and now the centers now they're being immersed in some online technologies, electronic technologies. But in these institutions, KPIs is the locomotive of development which moves the enterprises further. Are there any questions?
I would simply like to underscore that we've got 20 minutes left from the timing announced for our experts discussion. But we do also have the experts who are going to speak. Maybe by the end of the Mihail, I've only got a very short question: whether your institutions ever provided assistance to the foreign migrants out of the Russian budget? And do you account for this particular service separately? Do you register it, and do you assess its efficiency, effectiveness? Yeah, thank you for your question. Yes, we do provide service. If these are foreign citizens, then we do that through the insurance companies. If these are the countries that we have bilateral treaties, that comes out of the Russian Federation budget. Yes, certainly. But this is the special permission by the Minister of Healthcare in every individual case. No, well, I mean, that has been for several years now. Thank you. Please. Hold on a second. Just wait for the microphone so that we all can hear you. Yes, good afternoon once again. Last year, your centre was joined by the Polenov's Neurosurgery Institute, and the overall strategy that the Federal Minister of Healthcare is pursuing is merging together the narrow specialty institutions and setting up big complexes. Do you believe this is an effective way to go, and how do you assess the results so far achieved? And my second question is, your colleague, by way of an instrument of improving efficiency, chose to switch over to an autonomous status of an institution. Now, this particular instrument, is it effective, and why do you remain a budget-funded institution? Well, with respect to the Polenov's Neurosurgery Institute, this is an outstanding institution with 90 years of history behind it. It celebrated 90 years anniversary, the first neurosurgical institute, but because we have been developing this, and it so happened that in terms of the possibilities to run research and education in the center, and alongside we wanted to develop it together, so the Minister of Healthcare made a decision not to merge, rather, but because this is an affiliate, sort of a branch. And you may basically go there to the Mayakovska station and take a look at what happened to them during the past 18 months. And you can ask them whether they're feeling better or worse. So the kind of the advantages that the center had are in full way available to all of the Polenov's Institute personnel. And I believe that strategically that is correct. The strongest survives. Competition intensifies. And we created a cluster today in St. Petersburg, which includes now 5 major city universities: Polytechnical, ITMO, LITI, Chemical Pharmacological Academy, and in order to respond to the most complicated challenges related to the fundamental and applied research, there is no other way. One can build a small institution, fence it in, and live in there for some time, but that won't take long in order to see that it's not functioning properly. So what's important is for the capacity accumulated there not to be lost, for its history not to be forgotten. For me, as an alumni of the University Therapy Academy, is very important. So whatever we've got right now is our gigantic history, and our task for today and tomorrow, with this history behind us, to develop the best practices in science, healthcare, and education. Thank you. Yes, the most important answer was given in the very beginning, that you suggest that people can go and take a look for themselves. Indeed, dear colleagues, during the very short period of time, there's a very tangible change, without mentioning the strengthening of the HR potential. Yes, the size of the institute grew at the expense of the 3 divisions which have been opened in the middle, 2 adult ones and 1 children's surgery, plus intensive care. But I should say that have been given an inhibited surgical theatre, which is one of the top best 6 in the world. And the Polenov Institute itself, how good it feels itself right now. Narrow specialty. Can hear what he's saying. Not speaking to the microphone. Is it the proper strategy for the whole city? This is the proper strategy. You can have a narrow institution only as part of a major multitasking center. As was mentioned by my previous boss, Vladimir Almazov, there are many specialists, but nobody can give you proper treatment, unfortunately. Well, no, I'm talking about the narrow specialists. Well, again, I would suggest that the second question that colleague raised about the advantage of an autonomous form, and gradually to pass the microphone over to the head of a non-government healthcare institution, Andrei Vladimirovich Yanovsky, who runs the European Medical Center. So just to hear how these indicators are being modeled and how do they work in a non-government health institution. Well, surprisingly, they work in a very similar way, in line of what we're hearing in today's discussion. The thing is that the theory of the issue is clear. We're trying to highlight the target, we identify the areas of our attention, and mind you, whereas in the first presentation we saw three basic ones, and then in the subsequent discussions we've identified the fourth area, which was mentioned several times, which is satisfaction, and we do put it into the forefront because, like in the case of the previous presentation, very properly and nicely we've been told that in the center of the whole attention is the patient, and whatever is in the patient's mind in the first place, and whatever is then being passed by the patient out to his network, and the healthcare institution is being given this perception in the form of recurring visits and checkups. That is exactly the indicator of the level of satisfaction. What is going on here? Well, you should ask the girl. Yes, you should always ask the girl. I do agree with that. Yeah. So then on, we transform our target down to the level of an organization, and naturally we highlight three requirements which we impose on the company's: quality of the service rendered, maximization and retention of patients, which is quite natural for any healthcare institutions of any form of property, and whatever we discuss here, which is the stable economic effectiveness. Each of these targets has to be dissected into a whole bunch of elements which already translate into the management level. They are easily comprehensible, and our next task is only one. The way forward is clear. Now, who is going to be engaged, how this should be divided into various stages and areas, what should be a list of KPIs. I think that once some character said in the movie that everything has been stolen before us. In every presentation we heard it that any best practices, be it in Russia or overseas, can be adapted so as to put together a balanced scorecard, which, and this also was very much stressed today, and we know it out of our experience, is being put together on the basis of the most important tasks that an organization faces today. As we understand, these tasks may change, prioritization may alter, and that means that the balanced scorecard can also change. First, from the point of view of the weights, the indicators itself, the weights attributed to them, and respectively those who are incentivized finally to achieve these indicators, and how this is being reflected upon the system of incentivization compensation, how deeply this is immersed, and whether there's only one functionality that it is trying to reach, or this is about a set of indicators that a group of people is responsible for. In our case, I would simply add that the area that is described as satisfaction in this first place, this is the quantity of valid grievances, and additionally the lack of any litigation cases, which in the majority of cases people may initiate. We do put it into the area of quality, undoubtedly, because under quality one should consider specifically the healthcare assistance, which can be assessed only by a professional. Satisfaction is being measured by a patient. I will not describe myself as a very popular person in the industry, but I'm more than confident that the non-professionals are assessing it. So for them, not only important are the services they received, but the way they were given explanations, how they participated in the process, what was their mood that they came out of this process with, and what they can further tell to the people around them. Meaning to say that a physician becomes responsible for the marketing component in this whole process. And further on, what I would like to note that based on our experience, we made a decision to divide this functionality into two parts. Now, why we believe this is justified? Because as a rule, a senior physician is an expert, a practitioner who is well knowledgeable of the areas which are described as quality and safety for a patient. However, the second part of these efficiency indicators, and particularly the ones which are not strongly related to the healthcare process, but rather with the support for it, do relate to the area of an operational manager who knows better about the business processes, how it should be built, how the logistics should be evolving around it, and how one is supposed to achieve the very same efficiency or the economic effectiveness. And so we split into two parts. And after that, in a natural way, there is a distribution in between the various tasks. And here I allowed myself to emphasize, because the task of switching over to the patient-targeted operational model I distributed between the participants. OD is an operational director of a healthcare institution, and M stands for a person who is responsible for the healthcare provision. Zo is the one who is responsible for the support function, and the HCM is the Healthcare Department of Moscow. I simply just thought of this for the sake of presenting. And then I put together an attachment which shows how one should cascade the indicators in between these two key players. Once again, I would draw attention that our experience shows that the very first area that we're busy with, providing for the quality of the healthcare service, but exactly the same kind of the right hand is the patient satisfaction, because for a healthcare institution, for example, within the government area, if I understand correctly, in Moscow, it's about exactly how many patients would attach themselves to this specific healthcare institution, which may not be assessed by the classifieds in the newspaper, but simply through the measurement of how the satisfaction level grows. Another comment that we openly debated today and expressed our reservations is that one shouldn't be really measured by the same yardstick and monitor what kind of an indicator is being set. We are being guided by one particular principle in our work. One have to honestly measure what is currently going on and then monitor the trend which is happening for the better, or God forbid, for the worse, but that should be the trend per se. And then the healthcare department knows better than we do how one can identify classes of healthcare institutions for them to be comparable. Otherwise, this would be a demotivating, de-incentivizing factor for this or that participant of the statistical competition. So, in a nutshell, this is it, so as not to take up too much of your time. Thank you very much. Thank you, Andrei Vladimirovich. Dear colleagues, are there any questions, please? I've got the following question. Your expert opinion, something that we've been talking about today already. If I understand correctly, if a physician in a district clinic learns to explain to a patient why he is giving him this kind of prescription, why he's hoping to get this kind of results, competition for you will grow very much notably, will it? Oh, yes, it will, but it would be even better for this particular drug to be prescribed in a proper way, then it would definitely go then. Thank you, dear colleagues. Before passing the microphone over to our next expert, I would like to apologize because in about 5 minutes I will have to leave this room and move into an adjacent auditorium. Very briefly, I would like to express very deep satisfaction with today's discussion, not because of very substantive, constructive, and I would say the kind of discussion which contained many elements of best practices, and this work shall continue definitely, but most importantly from the questions that we hear from you, because they demonstrate a high level of interest and engagement, showing that we have to combine, not just through planning key performance indicators, this is not just a stationary something, because this is an evolving matter whereby we've got to combine the trend in the development of the overall healthcare system, as well as the way the patient community perceives the quality. And so this nature of the process has been noted by all of the speakers, and the should emphasize this by identifying this patient centricity as a term. So before leaving, I would ask for your consent to pass the role of the moderator to Academician Schlachtel and to give the microphone to the senior physician of the hospital number 1 in the city of Moscow, named after Nikolai Pirogov. And before Alexei Viktorovich will start his presentation, I would like to say that the classics of the Russian Soviet healthcare and organization of the healthcare system, Nikolai Pirogov, has the quote, owns the quote, which has been interpreted in many different ways today, many times, who used to say that in the theater of battlefield, when providing surgical assistance, what counts is not just the art of a surgeon, but the art of the organization of the healthcare processes. This has been mentioned 100 years ago. Yes, thank you very much, Igor Nikolaevich, my dear colleagues. I'm in a very big predicament, considering the fact that we're logically coming to an end of the session. You see, to be the last speaker is a very convenient thing on the one hand, because you hear, after you there will be the head of the Federal Healthcare Oversight Service. Well, I'm infamous for knowing how to chip in. It's great to be the one speaker before the last. But what I wanted to say is when I was listening with great interest and attention to the presentations of my colleagues, where we heard specifically about the new era of healthcare, I should say, about high level of patient compliance and what we're supposed to do for our patients, and how this is transformed into the very system of these key performance indicators. These are the indicators of success of an institution, the core indicators of the success of what you do. And basically speaking, the success of an activity of a health institution, if we are not talking about developing and improving economic model, which is in the foundation of the healthcare, amongst other things. In this case, we ought to say that these are the two, as I am thinking, main components on the basis of which we are in a position to assess these key performance indicators, which is the system of management accounting, and this is the system of risk mitigation and management, which comes to surface in the description of any process, be it a healthcare institutions or non-healthcare institution. We ought to begin by saying that currently we are going through this matrix argument. All of the 2 years that I had the honor of working in the First City Hospital, this is a multi-tasking, multi-profile inpatient clinic with 1,000 beds, with all kinds of high-tech healthcare assistance. We have our own nursery. We've got about 100 in beds in intensive care unit. We treat everything apart from the open cardio surgery and transplantation. Our core key performance indicators, they are quite standard, I should say. This is the efficiencies of a single bed. This is the average cost of a completed treatment case. This is another very important element, which is the utilization of in a proper sense of it, of the kind of equipment that we have in our employment. For example, 3 computer tomographs in the First City Hospital, 2 of which work 24/7. So we look at it in 12 months period. It's 49,000 analysis, out of which 63% is for typhoid, and for 47% is contrast analysis. Based on all of the global criteria, one computer tomograph is supposed to do 8,000 analysis a year. In this case, it's being considered to be effective. The thing is that whenever we talk about key performance indicators, you see, they are being put together for institutions, for the units within these institutions, and ultimately for the personnel who works within these units. And for every group, and respectively for every professional, they are different. And in order, apart from the indicators which has already been functioning successfully, I don't think that there is a need to enumerate all of them. Of course, these local clinical protocols. Of course, this is a very precise following of all of the recent guidelines in pharmacotherapy and antibiotics therapy, multidisciplinary approach, because we're not treating a disease, we're treating a patient. There's a very coherent logistics for the entry, in other words, I'm not going to waste your time. Being a senior physician, both a physician and a manager, every morning looking at my computer screen, I got to see 10 key performance indicators which would enable me to assess the work of my inpatient institution, which is made up, basically speaking, out of various material values, made up of an effective operation of my people, and which is made up as a consequence of it, out of a successful interaction with the patient and the satisfaction on the part of the patients with the service received. So basically speaking, this, yes, and considering the fact that effectively these are the three main pillars, I may tell you that just one, let me say, logistical procedure of changing the surgical schedule once the surgeons start doing their job at 8 o'clock in the morning rather than 10. First, they went into a conference every day. Whenever the report, was printed out on the piece of paper, right now, we developed this IT system whereby I am able to see everything. I can see my patients, I can see their status, I can see the warehouse, I can see the pharmacy, I can see the balances remaining for the day, I can see how much I'm supposed to pay on different contracts today, how much I'm supposed to pay on them tomorrow, how do I trace my balances. It's really very much encompassing, because you start understanding what is a management matrix, having served your whole previous life as a cardiologist. So 2015, comparing it with 2013, is 35,000 surgeries. Urology, gynecology. I'm not talking about injuries, compared to 22,000. So the average bed day, 7, 9, about 475, 578. We can talk about, as they say, the average temperature throughout the hospital. We can assess the average cost of a completed case within a hospital where you've got injury and orthopedy, where you've got a patient who spent 2 weeks on hemodialysis, or a patient who had gone through a severe hemodialysis case. This amount of money reminds one of a telephone number, rather, in terms of its size. But nevertheless, we've got to rely upon these daily indications. Further on, this is the system which has to continuously improve. On the one hand, it has to be a completely unified one in order for us to understand in any given point within the system, having gone into it, so we understand what is the status of everything going on. On the second thinking, considering the particulars of an inpatient process, this is a very lengthy period of continuous development. Thank you very much. Alexey Viktorovich, thank you very much. Just 1 or 2 questions to Alexey Viktorovich. Excuse me, have you ever had improper diagnosis issued, and what do you do in this case? Improper diagnosis used to be, they do exist, and they will remain in our work. In such cases, there is a standing commission for medical mistakes in hospitals which analyze such instances, which trains physicians through the example of such cases. This is an absolutely inextricable part of the work we do. Dear colleagues, we are facing a critical situation with timing. Mikhail Albertovich, you're in charge of the healthcare oversight service. Mikhail Albertovich Murashko, whatever we've just mentioned about the key performance indicators, it's all good, but if Mikhail Albertovich will follow different kinds of criteria, it's going to be very difficult for us to do our job. So what are your impressions? Yes. Press the button, please. 1, 2, 3, it works. Esteemed colleagues, just a couple of 2 or 3 minutes. Of course, I wanted to listen to the discussion more and what kind of a conclusion I came to, having heard the experts speak. I mean, we've got several institutions and the head of these institutions speaking in front of us. And realistically, one of the best institutions in Russia, that these are truly the centers where you can receive a very safe treatment. And we, as a controlling authority, we may say that we audited all of them, and that is exactly the case. But there is one but. Even the present and the speaking, very reputable people spoke of different things. Today, the first half of the day, when the minister was here, she was talking about the standards. And today, there is just one trend, and people are talking approximately about the same thing, but everyone is mentioning different nuances. What are the other institutions to do which are not as successful, not as well equipped, and which are not as well stuffed with potential and competent people? It's more difficult for them. So we're talking about the standards that we have to approach and the systems which are applied to the internal control, to the quality management systems, etc., etc. So today, what I do clearly see that the industry which is supporting us with the medical devices, and pharmaceutical products in this particular issue have really gone very far. This is the well-known GMP and the best practices that we are very much familiar with. This is the ISO 13485. These are undoubtedly the fundamental things which should be in existence. Today we've got a number of hospitals which introduce the GCI system for them. We are not able to really disseminate it throughout the whole country because participation in it is from $60,000, not to include the per diem, so that will never happen. So this is the start of various processes which enabled inside institutions, and we have finished today one of the stages. One of our institutions is going through the experiment, and we would launch it for the inpatient systems. Very simple things which are mandatory to be done. The next thing is in outpatient ones. And here I want to say that there are two things that we mentioned. The checklists. These are the things applied and the clinical guidelines which one should have in every institutions, individualized for these particular institutions. So you have to select from the general things that you have to do in your institution. And the next stage is what the organization, the organizers of the health institution do in maternity. The number of beds was reduced, the fatalities have reduced, the disabilities have reduced, and even the criteria of birth from 500 grams of birth weight. So a major step forward. In cardiology, a major step forward, but there are certain areas where these still have to be developed. In orthopedics, this is moving quite nicely today. So whatever we see today is that the standardization of the approaches to the system of management, quality management, is a very important thing. So let me not say anything more. Another thing for you. Today, legislation allows to develop the quality management system or internal control independently. Every senior physician makes his own decision, and we've been able to hear it today. Even auditing whatever the heads of these institutions do, we see that 45% don't act on what they have written down. So to be able to say that there are ways to improve in the country, definitely there are. And I absolutely support whatever Konstantin Viktorovich was talking about today, these principles, where a patient wants to go to get a treatment close to home. So this is an eternal problem. So one should explain and not get tired of it, and only then this process will move, and it would enable the system to realistically be effective. Thanks again. And I would like to also thank, because we've got the Minister of Economics present here, because this is the institution that we are in a lot of debate, and they're helping us. This is one of our major people who support us to develop legislation in a better way. This is an individual who worked over the federal law number 323. Dear colleagues, they are professional managers, and this enables the industry to work as an industry. Thank you very much. Thank you, Nikolai Bertrovich. Dear colleagues, just a couple of words in conclusion. Without any doubt, it seems to me that we did not spend these 2 hours in vain. Excellent presentation, brilliant ones by Igor Nikolaevich and all of the speakers. Great many thanks to Mikhail Albertovich for almost strategic wish what I would like to say, without any doubt, we do require individual programs for the development of every institution on the basis of certain common criteria. Common criteria is a rule like of road map. But what kind of speed, what kind of vehicle, that is for every institution to decide in accordance with its capacities and opportunities. The next very important thing, a transition to the checklists and clinical guidelines. But what is even more important, the patient protocols. So I do say this is very, very important. Educating people. Without it, we won't be able to move on. But education, today it seems to me that it has slightly shifted towards the simulation education, because I believe that supporting the patient, that we've got to train our students not only in a simulation mode, but also to remind them that there are human relationships, which is also very important, because whenever a pilot tells you that the probability of safe landing is 95% was developed with a simulator, who will be willing to board such a flight? So I do say that simulation is very good, computer simulation, but just remember that a doctor and a physician is not just a procedure. This is also a conversation with the patient. And I do say this is very important. Commanding approach, checklists, education and training, program for every healthcare institution, and we definitely ought to be patient-centric in our healthcare system, which would be based upon the key performance indicators. And that is definitely our request to Mikhail Albertovich in terms of this whole analytics to be amassed together and together with us to come up with a certain criteria for different institutions so that all of us would be better off working for the interest of the patients, not to be afraid, but not to try and chase the quantities, but rather think about what the consequences will be of our interventions, including the social consequences, not only the economic ones. So with this optimistic note, I would like to conclude and wish all of you success.